maybe good morning and good afternoon and good evening to you all. So today we are going to talk about claims processing session one. We will be covering the basics. We have two speakers today, MalarPriya and Anup Das. Will introduce myself. I am Harsha. I'm working as business analyst in one of the life sciences project as a business analyst and data modeler with good experience in healthcare. And I would like to introduce my speakers today, Malarpriya and Anup. Malarpriya is working as a lead business analyst with 9.5 years of experience in IT. She contributed in various roles as a techno functional business analyst, product owner, SME, tech lead, and also as a developer. She also possesses vast experience in domains such as US healthcare, travel and hospitality, global trading, and legal uh, in technical BA or PO roles. That's about Malar. I would like to introduce Anup, who is going to be the second speaker for today. Anup is a senior business analyst with 10 years of experience in IT. Um, yeah. So it's about our both speakers today. I will quickly go through the agenda for today's session, right? And we will be talking through all the claims basics today. We have planned two sessions on claims. It's going to be the session one today, as you see in the invite and in the course, and also the second one is going to be the advanced. So in today's basics session, we'll be talking through on managed care organization process business process model, claims lifecycle deep dive, decoding claim types, funding and payouts, claim adjudications, why claim processing is hard, performance metrics, implications to shape claim processing. So in this agenda, right, and in the next 1 hour, it's not going to be only our speakers talking or me as a moderator talking. We also want to keep this interactive, and we'll be sharing some of the Mentimeter to get your inputs, and we'll talk through it, and also we'll have quiz at the end of the session, and we also have a leaderboard which we will be presenting, and uh, I hope we'll enjoy this session. Thank you all for joining once again, and over to you, Anup. Maybe I will share that link. Maybe
Sure, sure. Thanks, Sasha. Hello, everyone. Nice meeting you. Today's claims processing session one, and as you can see here is uh, I think a plot of cost versus access, graph. So before going into this, let me tell exactly what a managed care organization business process model is all about. So it's basically a framework that outlines the structures and the key components of a managed care organization's operations and its revenue generation model. As we can see, the higher you go up with the access, the more cost is obviously coming from the members or the providers, and the more access you have in the claims for all the services that you are taking in hand. Now, for example, you can see for HMO, which is I'm sorry. HMO, which is basically health maintenance organizations. The primary care physician and the services that is provided, they remain inside the network, uh, and the cost is also minimal. Now, if you want higher access, you go to PPOs or POS, which is point on service sales or preferred provider organizations, uh, where some of its PCP is inside the HMI network and the freedom of out of network as well. But for PPO, you can see both are out of network and there is more freedom. And once you go to indemnity, there is no network concept altogether. You have complete access to all the managed healthcare options or services that you can take with higher cost, obviously. Now, uh, MCO entities administer and coordinate these healthcare services through a defined population of members, typically through contracts with healthcare providers, insurers. And the main focus of this model is achieving, high cost effective care delivery while maintaining high standards of the services provided or for the care provided in the claims as well. So now moving on to the next slide. Yeah, sure. So now that we have a good overview exactly, what MCO is, what are the key elements, that is consisting inside the MCO? So first is the membership, whether it is patient membership or provider membership, and how MCOs generate revenue out of it is by enrolling members who seek basic healthcare coverage or advanced healthcare coverage. Members can include individuals or employers or government entities, and they offer MCOs offer different type of health plans, as we saw in the previous slide, such as HMOs, PPOs, POs, POS plans or indemnity plans, which is available for the membership. For the members or the providers. Now, moving on to the next key element is the provider network. So, MCOs establish these networks through the help of healthcare providers, which includes hospitals, physicians, specialists, and other healthcare facilities or professionals. And how this happens, they enter into contracts with MCO and the network to deliver the services as per the terms and conditions that has been provided to the enrolled members. And there is a negotiation that happens on the reimbursement rates or the premium rates, which helps establish quality standards with the provider. Now, coming to the next key element is the payment management system or the premiums management system. So, how MCOs achieve that is through the revenue they receive through various, payment mechanisms. For example, in commercial plans, members pay monthly premiums to the MCO for their coverage. Alternatively, MCO may receive capitation payments from government entities or employers to also manage this payment system. And capitation payment mostly involved a fixed monthly payment for per member to cover their healthcare needs, regardless of what actual services that is being rendered to the member. Now, moving on to the next step or the next key element that is as part of MCO is the claims processing, which is we are going to discuss in the upcoming slides how claim processing works, which is a major step here. So MCOs handle these, processings of claim or claim adjudication that have been submitted by providers by evaluating, various factors like eligibility, accuracy, and the compliance with the coverage policies. And once the claims are processed and or reimbursement payments have been, done, which is also determined based on the negotiated rates, contractual agreements, terms and conditions that have been provided in the particular claim. Now, moving on to the next step of next key element is utilization management. So, what happens? What this key element is all about? It's how MCOs implement utilization management strategies to ensure that appropriate use of healthcare services and the costs are controlled for the services that have been rendered, which includes prior authorization, concurrent review, case management, and other various steps. And these and in return these help monitor and manage utilization of services, ensuring they are cost effective and necessary. Now, moving on to care coordination, quality improvement. So here MCOs prioritize that initiatives have been improved and enhanced for the overall healthcare experience for their members. Members have good idea exactly what are the next steps and the process they're going through. And there are various matrices and monitors that provide performance to ensure there are adherence to clinical guidelines, member safety standards, positive, health outcomes, and MCOs implement initiatives to improve member satisfaction, like through surveys, feedbacks on care coordination, and other health outcomes as well. Now, the next step, which is also key element, which is also related to quality improvement, is member support and engagement that we discussed. So, how MCO acts here is by providing member services and support to address inquiries, concerns, complaints, and the methods I already mentioned are feedback, surveys, and these are done through the service channel or health education channels and other resources that are there to help members navigate through the health system and make informed decisions of the claims or about the health services they are getting, that is being rendered to them. Now, a major key element of MCO is cost management, and it comes across all the board, like premium cost management, claims cost management. And this includes negotiating favorable reimbursement rate with providers, implementing cost containment measures, promoting cost-effective prescribing practices, and encouraging members to utilize in-network providers and preventive care services. And the last key element that the MCO looks into is the regulatory compliances. We know about HIPAA compliance and other key compliances in the US health market. So MCOs operate within those regulatory framework defined by the government agencies and industry standards. As I mentioned, HIPAA is one of them, so that there is quality reporting, financial solvency, network adequacy, and consumer protection. And obviously, privacy of data is protected. So these are the major key elements in MCO. Now I'll be handing it over to uh, Priya to get the details into what is claim and what are the next steps in claims lifecycle. Thanks. Priya, over
Thank
to you.
you. Thank you, Arnab. Thank you for the detailed explanation of MCO. So, as he stated, the main key element in MCO is claim processing. And that is why we have this session today. And this session will be the basic session, but the detailed session will be on the coming Friday, the next Friday. Okay. But now I would like to ask you, participants, to unmute yourself and tell me what is your, wild guess about what is claim, right? What is coming into your mind when I say claim? Do you have any experience in applying for a claim reimbursement, or you for a hospitalization or anything? If you have any claim experience, right, would you please share with us what is claim according to you? Can anyone unmute yourself and help us with your experience in your real world?
Well, I paid for something and I'm now asking my insurance company to pay us back.
Exactly.
And
So that is a very short explanation and a very crisp and correct explanation. So it is just a request for payment submitted by a healthcare provider or member themselves to an insurance company or a managed care organization, that is MCO, for the service you have utilized or the services rendered by the provider. So that's it. As Florian have stated, it is just a request for payment to health insurance company. But how the request is being made, that is what claim processing is all about, right? As in a high level, okay, so once the hospital receive the information about the health insurance and everything, and they have the services, that is, you have already been there, so that would be some bill, right? So there would be some hospital will be there. If it is hospital bill, if it is pharmacy bill, a diagnostic or any lab center, so anything will have a bill. And to comply with HIPAA standards, so they have to send this claim in an electronic way using EDI X12 837 message format to the insurance company. So they will collect all the insurance details and they need to send it to insurance company to understand whether this particular person have the claim eligibility or not, right? The benefit eligibility or not. But how do they send that request? Via X12 837 message format. That is the format that they need to use so that they can comply with HIPAA. Right. And in return from insurance company, they will get the remittance advice. But in what format? Again, in X12 835 message format. That is what required by HIPAA. That is how you can remain compliant with HIPAA. So the request is 837, and finally you will get the remittance advice that is in 835 message format. But what is happening in payer side really? First, they will receive the claims data, right? And then they will check. to avoid any duplicate claims eligibility, because the member can submit claims and again, right, for the same treatment that they have applied for. So they will check for duplication, if any. If the claim is not a duplicate, then the third step is benefit determination, whether this member is eligible for this particular treatment, particular benefit, whether they might have already exhausted their amount that was allocated to them. So they will go through, the claim will go through all this benefit determination. And then the fourth step is analysis of provider details. But in some rule engine, the rule engine that I worked, so the fourth step will be our third step. First we will analyze the provider details, then only we will go through the benefit determination. So it may vary, I would say. So analysis of provider details, that is, if the provider is valid provider, first thing. Second thing is, if the provider is valid provider for providing this treatment. For example, not everyone can give you controlled substance drug and treat you with some cancer or any end stage diseases. Whenever you are handling controlled substance, you need to have a DEA membership, otherwise you can't provide such treatment. So there are so many underlying things are there. So they will analyze the provider details. And then the fifth step, which is the coding, bundling, diagnosis review, which is what we are going to see in our session 2 in a detailed way. But for now, what is coding, bundling, diagnosis review and all is actually you are collecting the information in natural language, but the system will not be able to understand it, right? So we need some sort of code mapping, so that then it will be further processed, and then further review will be applied, and the rule based edits will be applied, and finally it will move to the claim settlement and presentment stage. Okay, now moving on to what claim constitutes of. So if you have done a paper claim by yourself or for reimbursement, or if you have gone to hospital or anything, they will ask certain details from you. So what are the details they will ask for? First one is member information and the member demographics like name, date of birth, address, insurance information. Oh, sorry, address, insurance information, and so many things. And the provider information, they themselves provide the provider information, or if you are submitting your claim, you have to provide your provider information. And what includes in the provider information is NPI detail. Specifically in US healthcare, it is NPI detail, address, contact details, and the service. So what is a service that you have received, diagnosis or treatment or any cure? So what is a service that you have received? But if it is EDI, electronic format, we should not type in the service receipt. We actually need to enter the CPT code or HCPCS code for the relevant disease and treatment. But hope we don't need to worry about it. So if the provider is doing or any third party people are doing, so they will have this coding system built by themselves. So they will correctly map that, and the date of service, charges and cost, and insurance information. So all these details are need to be there, and then only this claim will be sent, right? And moving on to the claim life cycle. So now we understand like what are the details that we need in the claim, right? So what is the first step then? Claim creation. So claim creation itself will involve lot of manual effort, because we need to provide correct details, otherwise claim will be rejected. And the second one is claim submission. From claim creation to claim submission, so how to submit the claim, how to apply the coding, how to apply the edits, that may vary, but everything will be same as that of the standards that we need to follow. Okay, and most of the time payers will have their own portal and you have to apply via their portal, or sometimes payers will have a third party vendors who will process the claims for them. So they will give all this details to our system. So there will be a switch between provider and the payer. The switch will recognize it and they will route the claim to the corresponding party. And finally, whether it is a third party vendor or PBM or a payer, whoever it is, once the claim is intaken by them, it will undergo the verification, claim verification, whether that is a duplicate claim or whether the codes are entered correctly. For example, disease may be something else, and the treatment might be something else. So there is a medical necessity or not. So all this verification will happen, and if the verification is succeeded, then it will move into the claim adjudication state. So what is claim adjudication? Claim adjudication is where we will get to know what insurance will pay, what a member need to pay, what government, if you are going through some government program, what government will pay, and what is the discount that will get applied here, do we receive any subsidy or not, you know, all these things will happen here. And also finally, what is our co-pay or co-insurance, or if it is deductible, if customer patient have to own the complete amount, you know. So all these details will be finally we will get only through claim adjudication. Or sometimes the claim can get rejected during the claim adjudication as well. Maybe you have already reached your maximum benefit, then after reaching the maximum benefit the claim will get rejected. So if the rule is like that, then the claim will get denied at this stage, after the stage 2. So claim approval or denial, but whatever it is, whether the claim is approved or denied, they have to use the same format for sending out the message. If it is hospital claim, if it is pharmacy claim, they will use ncpdb format. And finally, payment. So some payers will use quarterly once payment, and some payment will reimburse very quickly, especially if it's a high cost claim, they will try to reimburse in a shorter way. And some payers will use half year once payment. So that will vary from payer to payer. And claim reconciliation. So, what is claim reconciliation? Right. So, if you have entered everything correctly, then there is no problem. But then, if anything that is missed and the denial happened, you know, because of some missing information or anything, then the claim will go through the claim reconciliation as well. And finally, appeal and resolution. Mostly, you know, clearing houses will be there who will take care of all this appeal and resolution. But sometimes payers themselves will have the separate unit to take care of this appeal and resolution. And coordination of benefits. So coordination of benefits is not the final stage always. So I just put it in the final point to talk about it specifically. So what is coordination of benefits? Let's assume a patient have two insurance, okay, primary insurance, secondary insurance. And US healthcare have a government system which will maintain all insurance information very well. And if the patient has applied for a claim of $100 with the primary insurance, but the primary insurance will cover only $80, okay. So for the remaining $20, they are going to apply to secondary insurance because secondary insurance has that coverage as well. But if they are applying to secondary insurance, they can apply for the same $100 as well, right? So how to prevent it? So that is why we have coordination of benefits. If you follow this coordination of benefits, this $80 information that is covered by primary insurance and what is the remaining amount, all these details will be sent to the secondary insurance via primary insurance themselves. So that finally the customer will get only 100% of the amount that he spent, not more than that. So that is what coordination of benefits mainly about. And finally, the account resolution will happen. So this is what about claim life cycle is. But who are the people involved in each stage? First, the creation. Claim creation can be done by directly the members themselves or insured individuals, or we will have healthcare provider, they will do that. And similarly, once the claim is intaken, so payers or third party vendors or clearing houses can do that. And payers, adjudication, whoever is taking that, so they will do the adjudication. And claim approval and denial is once again the same people. And the payment, when payment comes, some most of the times it is payer who have to process the payment. But sometimes PBMs also, if it is a pharmacy claims, right? PBMs also, if the contract is like that, they will provide the payment and finally they will collect everything from the payer. So finally, at the end of the day, it is payer only. And appeal and resolution. So most of the times it is third party vendors, but payers also themselves have this unit and they can also process that. And moving to, where does claim actually originate from? Of course, it will originate from member. But what are the other things, other areas the claim is originating from? First one is healthcare provider, that is hospitals, pharmacies, clinics, some physicians, yeah, and laboratory, diagnostic facility, dentist if it is a dental plan, and third party billing services. This is where the claim is originating from. So based on this origination, we can classify the claims into different types. The first type is professional claims. Okay, CMS 1500, which is actually primarily used by physicians, outmember clinics, and therapists. Institutional claims. which is actually used by the hospitals, clinics, ambulatory cares, and dental claims, dentist, of course, and for dental plans, and pharmacy claims. So for pharmacies will use that, but they will use NCPDP format. And I want to call out other three types called as Medicare claim, Medicaid claim, Tricare claim. You can tell me Medicare, Medicaid, Tricare are also following the same CMS 1500 or UB04 or pharmacy claim NCPDP format. Why are you calling that as a separate claim? Why? Because when it is a Medicare, Medicaid, or Tricare claim, there is a specific fields you need to fill in, and the claim processing will also get a different rule edit. And finally, even after the claim processing, we have to do the PDE reporting and all. So the journey will get little bit of deviated from the normal claim processing, and you may need to do some additional steps. Even in the claim creation, you need to fill in so many other fields than the other claim steps. That is why I wanted to call it out as a separate type. But other than that, we have only four types: professional claim, institutional claim, dental claim, pharmacy claim. That's all. This is a high at a high level. And moving on to who pays claims and how are they funded. So we know who are going to pay the claim, but how are they actually funded? So that is why we have Anup. So Anup, please take it forward.
Sure. Thanks, Priya. That was a very good information on what is claim life cycle and different types of claims that comes in US healthcare system. So now claims are getting paid to members, providers, other third-party vendors now, or pharmacies. Now, how does this happen? Where does they get funded from? What are the sources from where the claims funding come? So claims in healthcare industry are typically paid by various industries entities, and the funding sources can vary depending on the specific healthcare system and insurance arrangement. So some of the common example is obviously the payer or the insurance companies. Now they collect premiums from the providers or members, and they fund the payments of those claims. Moving on to the next is obviously, as it is a US healthcare system, if all the government funded programs like Medicare, Medicaid, and where do they get all these funding from? Either it is through payroll taxes, joint accounts from that is funded by the federal and state governments, and these funds are generally collected through the programs that is used to pay the healthcare provider for the services they have provided for or they are eligible for. Now, employer sponsored claims. This is very common. Uh, we as an employee for EPAM as well, we have our employer sponsored plans in which we have different coverages, and according to that, some part of it is covered by the employer, and some of it is self funded, which is obviously the next one. So what happens here is, the employers assume the responsibility of paying claims, typically a portion of the premium, and the rest of it is collected through the employees from the payroll deductions. Now, these funds are collected from employers and employees, and it is paid to the healthcare services that has been provided. On self-funded plans, some employers or organization opt for self-funded or self-insured health plans. What happens there is, employers assumes financial risk for paying the healthcare and for the claims instead of transferring it to the insurance company. So they directly do it, and they set aside these funds for the cover for the expected claims, and also may also purchase a stop loss insurance to provide protection against excessive claims. And so this is what is covered under self-funded plans. Now coming to member payments or patient payments. So here we have deductibles, co-payments, co-insurances, or services that are not covered in the particular insurance policy that was taken by the members out of insurance payments. And here, the payments are directly done to the healthcare providers or through the bills they have received from the providers or for the portion of the cost that the insurance company has already paid for through its share. The last one is, government grants and subsidiary, the last channel. In this case, the subsidies or grants that have been provided to support healthcare services and cover the cost of claims. and generally these come from federal, state, or local governments in the US healthcare system. Now, moving on to the next slide, we came across a term called claim adjudication. And Malar gave a very good explanation of what exactly claim adjudication is. Uh, Let me define it once again. So it is a process where insurance companies or payers evaluate and determine the eligibility and reimbursement of healthcare claims that has been submitted by the providers or members. So claim is reviewed, it is compared with the policy terms, guidelines, whether all the medical codes are covered or not, whatever the premium is being paid, whether it is in network, out of network, all these factors are considered, and then a final decision is made from the payer side to make the payment or reject the claim or deny the claim. As you can see, what all factors is considered by the payer? Policy terms, which has been given to the member or provider, contractual agreements, the schedules of the fee, like Malar mentioned, some take it half yearly, some take it quarterly. What are the negotiated rates that has been mentioned here? What will be the reimbursement methodologies, whether it will be checks or cash or direct account deposits, cost sharing requirement, what will be the sharing between the members and employers, governments, and other all those entities. What is the medical necessity and utilization? Now, utilization was one of the key elements in the MCO that we saw earlier. Then the claim review is reviewed, and adjudication decision is one of the factors that is being considered. EOB are the benefits which we talked in the previous slide, uh, how the payment is going to get issues, and denial or rejection handling. So these are all the factors that are considered when a claim adjudication process is, taken care by payer or the insurance company. Now, moving on to the next slide, Malar is going to give deep dive into what are all the different claim processing methods. So over to you, Mala. Thanks.
Thank you, Anup. So, when it comes to claim processing, historically, paper claims, that is manual claim processing, was the primary method in claim submission. We all know that, right? But nowadays, it is not, very less companies are using manual claim processing. It is more of a EDI, electronic data interchange, which is what I was talking about in the first slide, right? EDI X12 837 835 messages. So EDI is the main claim processing method where the claims are processed electronically, right? And the second one is hybrid processing, which is a combination of manual claim processing and automated claim processing. And the third one is the automated claim processing, completely automatic. From the coding to eligibility verification, policy rules checks, everything can be done with rule based edits. And what is the trend now? The trend is real time adjudication. So now we want to know where the claim is exactly in, which phase it is exactly in, what is the member's portion, what is the payer's portion, immediately, instantly. And that is what we call it as real time adjudication. That is why people are moving from different APIs to fast API, and different technology innovations are happening only to provide this real time adjudication. This is the trend right now. And moving on to the tools that will help in processing these methods, one is the electronic claims attachment, and that is what really helpful in providing it as a proof for EDI claim processing methods. And electronic fund transfer, which will help in payments, and direct data entry, clearing houses, and practice management integration with our payer system, so that they can do the claim processing on our behalf. And EHR integration is already in place, so which is also the main supporting tool for this claim processing to be automatic. But given saying all that, why claim processing is hard? What do you think? Can anyone unmute yourself and give a wild guess on why claim processing is hard? What do you think? Maybe we are not insurance company, but we are members as well, right? So what do you think? Why claim processing is hard? Data quality, of course. People will enter the incorrect data or missing data. And what else? Can anyone guess? Anything other than data quality? Complexity of the rules. Yeah, of course. If you have the ineffective system, right? So let me show you like why claim processing is hard. So as rightly stated, that is the first point, missing an inaccurate data. And the second point is manual processes and disparate systems. So when you have the lot of manual processes, and that can be lot of glitches that can happen, though you are experienced person. And the multiple touch point, if you design your process with the multiple touch point, definitely that will be a bigger issue. And the fourth one is slow claim resolving time. So if you are providing the delay in claim resolution, why we have a delay in claim resolution? Maybe we have a ineffective claim management legacy systems that have complex rule engine, right? So if that happens, then of course people will definitely not like it. So the ineffective claim management legacy systems and outlier claims, especially like claims that are of high cost, complexity, or unique circumstances that comes in, for example, claims for organ transplant, or high cost surgeries, or claims for um, yeah, slow resolution is a cause of the ineffective claim management legacy system. Yeah, of course. And coming to outlier claims back, if you have any extremely rare medical conditions, that will also result in outlier claims, because you will submit claim multiple time, and payer will have difficulty in processing it. And duplicate claims, when you submit lot of duplicate claims, and that will result in delaying other actual claims as well. These are some of the reasons why claim processing is hard. But now Anup is going to tell you how to make it right. Over to you,
Sure.
Anup.
Yeah. Thanks, Priya. So, audience, although you saw there are a lot of reasons why the claim processing hard, but there are claim adjudication metrics in place that is, gradually making claim processing easier and convenient for the members or healthcare providers or third-party vendors, nowadays. So the first is network adequacy. So here MCOs evaluate network adequacy, including the availability of participant healthcare providers, specialists. They make a very robust networks, which ensures timely access to care, reduces out of network claims, and enhances the overall claim processing efficiency. Now, moving on to the next one is provider contracting and reimbursement rates. So inefficient, contracts with the providers, negotiated rates, also, and having clarity on that is helps the members and the providers and other third-party vendors, in this particular point resolution. Moving on to the next one is claims tracking and transparency. One of the huge issues that happens with any claimant who is doing the putting out the claim and applying for the claim is unable to track where the claim is failing, what are the issues with the claim. There is no transparency on the data. I think MCOs are now uh, providing the ability to provide more visibility and transparency throughout the claim process. The next step where the metrics helps is fraud on the claims or abuse prevention. So here MCOs provide efforts in detecting and preventing fraud, waste, and abuse in claims processing. Anti-fraud programs, data analytics, proactive monitoring, help and mitigate these activities. Moving on to the next point is compliance, and we have talked about this across this session. HIPAA compliance and other state compliance regulations, federal regulations. So MCO, you know, strives to maintain these regulations and strives that payer providers, insurance companies are abiding by these regulations, so that there is no violation and it helps in easier claims processing. External reviews and accreditation. a trusted, MCO gives these platforms or gives the certifications or accreditations. Anyone who is more trusted is obviously, most trusted by the end users for claims processing. Timeliness, another major issues, claims. Uh, so the previous point which we saw, claims tracking and transparency helps in the claims processing timeliness. And MCO is striving to, remediate or reduce more delays in claims by removing all the inefficiencies or backlogs in the claim processing system. Claim denial rate, the next point. So more examination on is done on why previous claims were denied. What are the factors, whether it is data points, whether it is inaccuracy, whether it is transparency. So all these, points are being taken, and the denial rate is reduced by by suggesting better communication, more clear guidelines, effective claim handling processes, claim accuracy and claim gain rate. Again, data accuracy. So as MCOs assess the accuracy of the claims process, and they help maintain a more clean claim rate by reducing the percentage of the claims processed without errors or rework. A higher claim rate indicates, effective claim submission processing and reducing the need for rework. Appeals and grievance rate, evaluating the rates of appeals and grievances filed against the MCO. A high rate may indicate, that there is dissatisfaction among the providers or members. Now, how it is MCO is assessing all those data points as well, and uh, you know, uh, putting all the remediations in place so that appeals and grievance rate can be reduced. Uh, as I mentioned earlier, satisfaction surveys, feedbacks. So these measures are also taken by MCO and payers to, get the proper feedback on how they can improve, the claim uh, reimbursement or claim submission processes. Now, one of the most important thing is, although you know claims processing is everything is fine, but then there comes accuracy with payments. MCO is assessing, those data points on processed claims as well, evaluating whether the payments align with contracted rates, fee schedules, reimbursement methodologies, or frequent underpayment or overpayment issues happen. And these are, which problems indicate that there is a problem in the calculation of the claim adjudication process. Yes, this is actually complex. And the last metrics that is taken into consideration to improve claim processing is the technology and automation. Now that AI is in place, as you know, manual human errors are being replaced by putting more efficient systems into place, so that all these uh, errors or remediations can be removed. So I think these are the factors which helps MCO in very putting on a very stable claim system. Yeah. So Mala, over to you.
That's all. It's time for quiz. And as Florian was stating that, uh, advanced systems, having advanced systems in place will give you all these metrics. Other than that, achieving all
Mhm.
this would be really very, very complex. But now it's a time for our quiz. And I would request everyone to click on that link. And Anup, you
Yes.
can
So
share your screen.
sure, I'll be sharing my screen. Is my screen visible?
Yes, it is.
So I see only two participants. If anyone is joining? Sure. Let me start it. I think the questions will be appearing on your screen, and you have 15 seconds to answer those questions and submit those answers. And the next
Fastest finger wins.
yes, and the next subsequent question is going to come. No answers. Okay. I think the next question will be on your screen. But next question is on your screen. Yep. Nobody. This is the fourth question. Oops.
Okay, we can display the answers.
Yes, I think this is the last question. Yes,
Taurus,
Darius is the winner.
congratulations.
Congratulations.
Can you show the answers as well, Anup, for every question?
Sure. Uh, shall I post it in the group chat? I think
Yeah, yeah,
sure,
you can
sure.
post.
I'll post it in the group. Thanks, everyone.
Okay, great. Thank you all for
Any
joining.
questions? Any
Yes,
other
any,
questions, audience?
yes.
I have a question. Not seeing the answers yet, but one of the first points that was at the end, the check for a secondary insurance company to pay whatever the remaining 10%, and it's done at the end. But if I'm, I could start the process with two of my insurance companies at the same time, and then they don't know about each other because they only check this after they've paid me. That sounds like an error in the process.
If you're talking about coordination of benefits.
Yeah, that's right. That was this coordination of
Ah, okay,
benefit.
okay.
That it's only done after payment. And if I, start that process with two of my insurances at the same time, then they only coordinate that at the end after they paid me. That's a bit late, isn't it?
Yeah, yeah, your point is valid, but it won't be at the last stage. I just put it in last stage because I
Oh.
wanted to talk about it lastly. But even in the beginning itself, we will find out if the person having multiple insurance, because our CMS is maintaining a proper database. Every payer can have access to that, so they will find out immediately, and then only they will process, and finally, primary will be the responsible for initiating the secondary claim, and secondary payer will be the responsible person for initiating the
Cool.
tertiary claim. That is
I was
how it will
wondering.
flow.
Thank you.
Yeah. Sorry about it. Yeah. Thank you. Thank you, everyone. Have a nice day. And the answers are posted in the chat.